Good morning, good afternoon, and good evening, wherever you are, and welcome to the African Cancer Dialogues. Today, the African Cancer Dialogues is a series of continental conversations where we aim to look at new evidence and look at how it relates to our practice on the continent. Today, we'll be talking about the recently concluded American Society of Clinical Oncology meeting, and we're specifically looking at the gynecology abstracts. Joining us today, we have two amazing panelists, Dr. Susan Sitonje and Dorothy Lombay from Zambia. Ladies, welcome. Maybe give us a brief introduction and what you do.
Thank you, Miriam. I'm excited to be part of this panel. I am Susan Sitonje Sedabwe. I'm a clinical oncologist and I work at the Cancer Disease Hospital in Zambia. My particular interests are in gynecologic cancers, obviously, and that's why I'm talking about these cancers today.
Welcome, Susan. Dorothy?
Thanks a lot. My name is Dorothy Lombay. I'm also a clinical oncologist in Zambia, but my subspecialty is in brachytherapy over gynecological malignancies and genitourinary. It's very exciting to try and dissect the evidence and see how it applies to our patients and resources in Africa.
All right, excellent. Welcome, ladies. I think the first question I have is maybe just to get your thoughts around, I mean, you attended the sessions and maybe you could share with me which abstracts maybe stood out for you and why?
Thank you. So for me, the abstracts that stood out were the two studies that looked at cytoreductive surgery in relapsed ovarian cancer. And these stood out because I felt this was something that was applicable to Africa, where we don't have many resources, for instance, resources to get targeted therapy, because these patients usually do need targeted therapy. And therefore, these two abstracts, giving the patients who have relapsed ovarian cancer another option.
Yeah, to add to that, with the cytoreductive surgery in advanced ovarian cancer, it made us think a lot here as we discussed about the evidence surrounding these studies, in the sense that there were strict criteria that need to be met for you to get success, from the desktop 3 and the SOG1. And all of them, I think you also relate those studies to the GOG 213, that comes out a lot. There was reference as well in most of the discussions happening there at ASCO. The use, unfortunately, the use of bevacizumab still comes up, which might be an issue for us, Susan. But it was nice. I mean, in the coming years, we'll probably see the prices of targeted therapy coming down, and it will be something that we'll need to bear in mind, that if you have bevacizumab, it could be an alternative to start the patients on that maintenance therapy and have an alternative, because big surgery is also an issue. The expertise, the gynecological oncologist that you need to actually perform these fantastic operations that give you good results is also actually an issue.
Susan, maybe just for our viewers who may not be aware of the gynecology oncology group 213 study, maybe you could briefly give us the synopsis of what that was about and how that maybe translates to the current studies, the current abstracts that were discussed.
So the GOG 213 study, that was the initial study that was actually published in November 2019. And that looked at cytoreductive surgery in patients who have relapsed ovarian cancer, who are platinum sensitive. It actually had two arms, and also looked at the addition of bevacizumab initially, as well as maintenance. So the initial phase of the study, they analyzed the effect of adding bevacizumab to standard carboplatin paclitaxel. And the second phase of the study, or the second analysis, was actually looking at overall survival of cytoreductive surgery in those particular patients. So they did find that there was a benefit in adding bevacizumab. However, there was no benefit with cytoreductive surgery in this cohort of patients. The two studies that were discussed at ASCO this year were of a similar design. However, in these cohorts of patients, the use of bevacizumab was much lower than in the GOG 213 study. The resection rates in the GOG 213 study were also lower than in the next two studies, the desktop 2 as well as the SCO 1. And the difference in that might be due to, in the GOG 213 study, the selection criteria of those patients who were to undergo cytoreductive surgery was not as strict as in the desktop 3 as well as the SCO 1. And in the next two studies, the desktop 3 and the SCO 1, it was found that the selection criteria of the patients was actually very, very important. And only those patients who achieved an R0, I mean, the findings were that those who achieved an R0 resection had a better survival than those who had a less than that resection. And actually that those who had cytoreductive surgery but didn't have an R0 resection, their survival rates were actually equivalent or maybe even poorer than those who didn't have surgery at all and just had the standard chemotherapy. So the most important thing is actually selection criteria.
Yeah, no, I mean, I think that's a good point you raised, Susan, about the selection criteria, because I think that's been the critique of the GOG 213, that the intrinsic selection bias may have skewed some of the results. But I think you do raise a good point around, well, I have a couple of questions both to you and Dorothy, but maybe we can ask Dorothy first. One, how common is recurrence, ovarian recurrence in the patients that we're seeing on the continent who've had their primary cytoreductive surgery? And two, even in terms of the selection criteria, because of course these two studies definitely had a better sort of complete resection rate, but I think one of the studies that if you look at what they were using for the criteria, one of the studies I think was referencing the use of a PET scan. And even then, I mean, the study in China, their resection, the R0 resection rate was still coming to about 76.6%. So it begs the question, how are we selecting patients? And is there anything we can do in our context that would help us to better sort of sieve out these patients who are likely to have a better surgical outcome?
Yeah, thanks a lot, Miriam. Very important questions that we need to answer as we look at these results, because the first thing, our patients, even de novo, present in late stages. Most of them have massive ascites, and so that's the first barrier to applying these results onto our patients. Then the next thing about the cohort of patients that we see on the continent is that the first surgery usually has residual disease because of the lack of specialized gynecology oncology surgeons, and maybe even ICU space to allow us to get to those R0 and do adequate massive surgery. So given those two factors, already patient selection for the studies, both desktop 3 and SOC 1, one of the criteria was that the patients should have had very minimal disease in the first operation when they presented, which just isn't a reality for us. And just to take you back, that's why 213 kind of hits it for me, because if we're able to introduce bevacizumab, which is systemic treatment, early enough, maybe, you know, we'll be able to get some equivalent results, because primarily we don't achieve cytoreduction very well the first time around anyway.
So we're saying intrinsically our patients are one would almost say sort of primed to have suboptimal outcomes just because of the lack of surgical gynae oncology, surgical oncology skills and services. Is that correct? And then in terms of the one that I can never pronounce, bevacizumab, is it actually available currently in your setting, and what are the cost implications? Because it sounds that it seems to me a fairly esoteric or novel therapy in our region, but maybe I could get your thoughts, Susan.
Yeah, so we've had bevacizumab before, but it is quite expensive. So it is hard to get. It would be almost, well, as I would like to be as optimistic as Dorothy. Now we've got bevacizumab, we've got your PARP inhibitors, but these are still quite expensive. Therefore, for me, why I think these studies, we should look at them more carefully and try to increase our surgical skills. Because again, you need to ensure that the centers where these surgeries are happening are high volume centers, so that the expertise is very high. And that's where I agree with Dorothy that that is very important. But I think the cost benefit ratio of trying to increase our capacity for surgery, because that would be more permanent, would be very important. And that's where these studies come in. If we can convince our surgeons that this is the way we need to go. With regards to our patients, I agree with Dorothy again that a lot of our patients have high volume disease anyway, but we do have quite a lot of patients as well who would benefit from such surgery, who have like maybe, because what they needed to have achieved is an R0 resection at the beginning, and then should be able to achieve again another R0 resection in the second surgery. Yeah, so very tight, I agree, very tight, but I think it's something that we should be looking forward to in terms of costs. Yeah.
Yeah, no, I think you both raise an excellent point, Dorothy and Susan, in that we need to get the basics right. I mean, whether or not you have access to the bevacizumab, if we're not getting good basic surgical oncology, good surgery, good outcomes, then the patient is invariably prone to worse outcomes, I think. So, I mean, I think there's definitely a role in terms of getting our policymakers, getting the wider oncology community to actually invest in these particular skills. And I think the drive will probably come from us, I suspect. The other question I had is, in looking at some of the series and who to select for cytoreduction, and I mean for a secondary cytoreduction, they were sort of referencing the time post platinum-based therapy, and they also looked at some series were sort of looking at. I mean, I know some folks at Memorial were looking at presence or absence of carcinomatosis. Are those considerations in our region given the bulk of disease, and how do we sort of go around choosing those particular patients? And then for a very naive sort of question is, how do you determine platinum sensitivity in the first place? Maybe Dorothy, you can let us know your thoughts, and then we can move to Susan.
Yeah, I think with platinum sensitivity, we definitely have a defined parameter, which is the absence of progressive disease 6 months after the last cycle of chemotherapy. So that those patients are considered platinum sensitive if they recur going forward after 6 months. Now, the question for our setting is always, when did this happen? You know, because access to specialized care, for example, when you speak of Zambia, which only has one cancer center, when do women actually come back when they're recurring? Is it when their ascites has actually set in? So would that have been 6 months, or has this woman been sitting at home for 3 months with the recurrent disease? That's a question that I think our multidisciplinary team meeting talks about practically every week when we have such patients, to determine when the progression happens. So the barrier of access to actually determine when that progression happens is one thing that we have to determine. So when you speak about the studies, I think most patients in these studies had about 12 to 18 month holiday, so to say. But if I can quickly then move on to the actual benefit, the benefit for these interventions was something like 5 to 4 months, 4.4 to 5 months across the studies. And is that something that we can really invest in when you know, like those second surgeries, the cost of putting a recurrent woman through surgery, and the benefit is 4.4 to 5 months in Africa. What do you think that means? Is it something that we should invest in defining our protocols?
Susan, I'm curious to hear your thoughts. What do you think?
I would love to hear your thoughts since you are a surgeon much later. But first, I would like to say that, so you asked a question about assessing them, like the initial assessment for surgery. So in our setting, I would go in the route that the desktop study went, the desktop 3, which I think is pretty simple compared to the iModel plus PET-CT, because that's just performance status, amount of ascites, and whether you think you will manage to attain an R0 resection, which can be based on CT or even maybe clinical. So I would go with the ARGO score as the desktop 3 did, and not the China study, the SOC one. I think investment in surgery is very important because I think it would have translational effect into all your systems. For instance, it would serve not just the patient that you are attending to now based on these studies, but it will improve quality for your other patients as well. And when you take that into account, your costs will actually come down. Whereas when you are buying bevacizumab or olaparib for the one patient, you can't generalize, you won't really generalize that for the whole population. Whereas for your surgery, I think you can generalize it for your whole population. You would have increased capacity generally. And that's why I'm advocating that we need to think about these studies more importantly. So I would like to hear from you, Miriam, since you're a surgeon. Unfortunately, we don't have.
Sorry, I was about to say no arguments from this side of the room about improving surgical services, because I mean, we do know that 80% of cancer patients at some point in their journey are going to require surgical services, and some of patients may actually require repeated encounters. Now, of course, in terms of, we said one, getting it right is critical towards improving overall outcomes, but more critically as well, I think even as we improve surgical services, we also perhaps need to think about, as you said, the selection criteria, and I agree that the AGO score might be a more sort of practical assessment in our setting, but even in terms of the follow-up and ultimate how we navigate or how we track our patients post-surgery as well, or as an oncology community, also has implications, because as you're saying, Dorothy, you're sitting down and saying, okay, when exactly did the recurrence occur? And it begs the question, then how efficient are we at following up our patients? And are there perhaps some innovative strategies that we could employ where we're very good with our mobile phones and things? Are there ways that we could maybe think about or explore that would help to at least consistently help us track these patients? The other thing, as Dorothy said, is quite a number of our patients are presenting with advanced disease. I don't know, I'd like to hear your thoughts, Dorothy, in terms of the assessment or evaluation amongst clinicians, because I think the question we have as oncologists is, how do we help the primary health worker pick up this disease earlier? or how do we inform the public? So what is the message that we would want to communicate to colleagues in terms of, I know ovarian is a little subtle, but what advice would we give to health workers or the public?
Yeah. You know, a sort of fantasy that has always been on my mind is, I think Africa has done very well in implementing, for example, under 5 vaccinations and primary healthcare in that regard. And I think it's time that we took cancer care to that point as well. As you've rightfully put it, ovarian cancer is subtle, even in the best resource places. So the only way we would actually escalate the early diagnosis of all sorts of cancers is by having primary health care workers targeted at cancer prevention and cancer screening, such that if a woman comes with ascites, instead of people thinking of PID for 3-4 months, you know, they're already directing that because they're sensitive to it, and that's what they do day in, day out. There is no other way. I mean, as you know, cancer is a big problem, but even more in front of us is other things like pediatrics, maternal health. So you need to put cancer somewhere there in our primary healthcare system as countries in Africa.
No, that's a good point. That's a good point. Susan, any additions?
I think I totally agree with Dorothy. I don't think I have any additions apart from, yes, we need to get down to the primary healthcare level. Yeah, only in that way we will be able to solve this big problem. Yeah, we can't do it as tertiary, because otherwise we'll just be getting the stage 4s, and yeah, we really need to get down to the primary healthcare level.
Yeah, and I think there's probably an opportunity to sort of integrate all these services rather than sort of having them in silos, like, you know, having the maternal and then now having the cervical cancer screening, having something else. We're actually able to homogenize them such that you cover all the bases and look at the patient holistically, then there's probably an opportunity to pick up quite a number of these conditions earlier. Yeah, guys, so what else do you feel stood out for you at the conference in terms of the abstracts and discussion?
Yeah, so one of the studies that I quickly said, Susan, look at this study, was the STARS trial. That's the sequential chemotherapy versus the concurrent chemotherapy in adjuvant treatment of early cervix cancer. I think the concept for me is quite important to explore, because the toxicities of dual modalities in patients can be quite high, and our patients are already malnourished or have HIV and so on and so forth. So if there could be interventions that help stagger treatment, it's actually would be a good thing. So the STARS trial actually explored that, but unfortunately the trial mixed 3 arms, and the actual hypothesis failed to come out well tested. They had an arm that they just followed with RT. They had one with concurrent radiotherapy and one with sequential. GOG is currently actually doing a similar trial, but with the 2 distinct arms. So we're anxiously waiting for those results as well. Yeah.
So Susan, what were your thoughts on this particular abstract?
I was saying that this was a very interesting study in that it looked at, it had 3 arms, as Dorothy said, the RT alone, concurrent chemoradiation, which is what the GOG study is looking at in intermediate risk patients, and then the sequential arm. The sequential arm, I related it more to the advanced stages that the Outback trial was actually looking at, though in advanced cervical cancer patients, where they would give concurrent chemo-RT followed by chemotherapy. And I think the chemotherapy agents are all the same. I think it's an important study in that we know that in these patients, even after RT, we still have recurrences. So to look at whether adding chemotherapy after would actually reduce these recurrences. So I look forward to maybe more studies looking at the same question, and also looking forward to the results of the GOG study as well as the OUTBACK study. And then I'm sure from there we'll be able to have more insight into what we should do with these patients.
Okay, thanks, Susan. Dorothy, in terms of the typical patient that we see or that the patients that you see in your center, what is your routine practice, or how would you routinely manage these patients? And maybe you could also tie that in to the findings from the study that they showed that sequential chemotherapy actually had a slight increase in the disease-free survival. Is that something that you think would be greatly, readily translatable to your patient profile? I just want to hear your thoughts around that.
Yeah, I mean, well, firstly, we'll use this to advertise our lovely MDT. Basically, all the patients all the gynecological patients are managed in a multidisciplinary team at the Cancer Diseases Hospital. And we're fortunate to have very small numbers, but at least we have a service, a surgical gyn-onc service, and dedicated theater time for that. But so the early stages, which is stage 1B2 and 2A1, would normally go for surgery. The constant struggle are the long surgical lists and limited slots. So some of the early patients are actually pushed to the chemoradiation when they could have actually benefited from surgery. So I think that kind of goes back to the conversation that Susan very rightfully elicited about investing into the surgical aspect of gyn-onc care. With regard to the relatability of the results of this study, it's really, really hard to accept to change practice based on this study, because their randomization in the RT actually allowed for patients who we typically would consider high risk and push to concurrent chemotherapy rather than anything else. So unfortunately, as exciting, it's more hypothesis generating rather than something
practice changing.
Yeah, rather than practice changing. So we still have to wait for the GOG study, I think being led by Anuja Jingram in the United States. Would still have to wait for those results. But as I had earlier alluded to, even if it may increase the total duration, having less agents that are inducing toxicity in our patients, for me, I feel is always something that is at the back of my mind. And if sequential allows that, then and doesn't, rather than concurrent chemorad, then it might be something that will be worth it.
Those are excellent comments, because as you said, we do need to think about our unique patient profile. And as you said, quite a number of these patients are having significant comorbid conditions, and that may potentially impair their ability to withstand some of these toxicities. And again, you did raise an excellent point around the multidisciplinary management, which is standard of care, and it's something that we're hoping with time that we're able to expand models such as yours to different parts of the continent. Now that we're in the time of Zoom, we're hopefully getting more connectivity, and perhaps you can open it up to other clinicians in different countries or different areas who are actually able to tap in and maybe discuss challenging patients. So there's lots of opportunities, I think. But I think what I'm hearing from you both, Susan and Dorothy, is that this particular study, for instance, raises a couple of questions and very interesting concerns, but really nothing that's practice changing. And I think it's important to underscore that, because as part of this series, it's sort of breaking down the data, because sometimes we've all been a little guilty of taking one study and using that as the threshold of, or criteria to alter practice without doing a deeper critical dive into what is it actually saying. As you said, the devil's in the details. How was it actually done? Are they looking at purely intention to treat? How are they? What's happening downstream? So I think those are very excellent points that you both raised around these particular studies. And I think the take home has been that there is a need to invest greatly in the gynae surgical oncology services. We're happy to carry the call forward, but I think there's definitely a need for a multidisciplinary push from all aspects of oncology, whether it's surgical, clinical, medical oncology, to actually have these services translated into all our cancer centers. I don't know if you have any last thoughts or any other interesting areas that you want to talk about just before we conclude. Susan?
Not really. I think it's been nice talking to you, nice talking with Dorothy. I think it's been an interesting subject, and thank you for inviting us.
Dorothy, any parting thoughts or gems to share?
Well, other than the fact that you got to witness what I get to do every day, which is talk to Susan. So I live in a very interesting environment. Yeah, I think the continent, what as we were looking at these studies, first we're like, oh yeah, surgery, something that is within reach. But, the underlying targeted therapy theme still starts coming up. So we're hoping the global community will allow us to catch up and have access to these more expensive drugs that are just not a reality on the continent yet.
Yeah. Thanks, Dorothy and Susan. And I think, as you said, underpinning that is we need to absolutely get the basics right. We definitely need to improve our surgical oncology skills, workforce, and there's definitely a number of ways that we can do that as a broader oncology community. We could liaise with the surgical oncology, the surgical colleges in the regions or on the continent, and see how we could work together to better achieve better outcomes for our patients. So thank you so much, ladies, Susan and Dorothy. It's been wonderful chatting. I think my last sound bite is just relating to cervical cancer, because again, it's the #1 killer. What would you tell health workers out there? What is it that they need to know or inform patients about?
I think we need to look at a patient or a client holistically. We need to, when someone comes into my office, for instance, I need to check, have they examined their breasts? Have they been examined by a health practitioner? Have they done cervical cancer screening? Has their daughter had an HPV vaccination, etc., etc.? We need to look at, because I think the impact on just one patient, one client and one visit can be higher if we look at them holistically, rather than just say, as you said, we need to integrate everything. Not, this is a cervical cancer clinic, therefore I'll look at your cervix and then go to the breast cancer clinic, etc. Or this is an under 5 clinic, I'll just look at the child and I won't look at the mother, when they could have been a nurse in the next room that could actually look at the mother. So integration of services, I think, is very, very important, and I think would have a huge impact.
No, that's absolutely true. I mean, there was a study, I can't remember where it was out of, but somebody shared data around quite a number of patients who are on follow-up on at HIV clinics who were coming in with stage 4 cancers, cervical cancers, and we were saying this is simply unacceptable. Because then we're looking at, come in, get your medication, whatever's happening to your cervix, let's pray about it. But nobody's actively engaging or trying to find out. And particularly, I thought for me, it was particularly painful, I would say, because I'm like, this is a patient who we already know has an increased risk of cervical cancers, and for them to present with stage 4 on our watch is, just unacceptable, But Dorothy, I don't know if you have any parting thoughts. Sorry, that was just my one, where is the outrage moment that had me really, really unhappy.
Yeah, I mean, I am going to encourage that outrage. Like, that is how we should be looking at cervix cancer. It's a highly, one, preventable by HPV vaccination and secondary prevention. It's highly treatable, and it's beatable. And there's no reason why our women on the continent should be suffering this ridiculous disease, and we should be outraged.
No, let's keep on the outrage. It's definitely going to take us far. I think just as we're carrying the outrage to our policymakers, how available is the vaccine in Zambia? And are there any sort of national attempts to disseminate the HPV vaccine? And is it just exclusively for young girls, or are they extending it to people of both gender?
So currently, there's been a rollout of HPV vaccination. Currently, it's only for all 14-year-old girls because there was a shortage of vaccine on the market. Otherwise, the initial plan of the country was for 9 to 14 girls. So the target is 14 and then move downwards. Girls over 14 are currently not included in the package, unfortunately. It would be nice if they were, and currently not being extended to boys, obviously. However, the targets were actually met in the initial rollout, and the coverage was quite good. So it's quite promising, and I'm hoping that we'll continue seeing such good coverage with HPV vaccination, and hopefully in future we'll see the impact of the vaccination with lower cervical cancer incidences.
Okay, so Dorothy, any parting thoughts?
No parting thoughts.
Okay. Yeah, no, then I would say let's keep on with the good work. Lots of promising steps in the right direction, especially as relates to HPV vaccine. Lots of opportunities for us to think more about strengthening our surgical capacity. But lots of ideas and questions raised around these particular abstracts, and lots of opportunities for intervention, I believe. So thank you once again. It's been awesome chatting with you, and thank you so much.
Thanks, Miriam. Thank you.
Bye.